Hello, and welcome to the Duke Cardiology Conference. I'm Sunil Rao, Associate Professor of Medicine at Duke University Medical Center. Today's topic is bioresorbable stents, from concept to clinical use. And our distinguished guest is my good friend, Bob Applegate, Professor of Internal Medicine and Cardiology at Wake Forest School of Medicine in Winston-Salem, North Carolina. Bob, thanks for joining me.
Thank you. Thanks for having me.
So there's a lot of interest in bioresorbable stents, and I think some of that is consistent with some of the experiences that people have had with stent thrombosis and some of the confusion and perhaps panic with the lowercase p over very late stent thrombosis. So why don't you go through your slides and tell us what we need to know about the biology of bioresorbable stents and what we can expect in the future.
Sure. I agree entirely. I think that the timing for bioresorbable stents is really on us now, and I think the technology that is really exciting to talk about. So I think this is a story that we all are probably versed in extremely well. The introduction of plain old balloon angioplasty in the late 70s, the ability now to percutaneously, revascularize patients. Recognizing a limitation, I think, in fact, as we'll see in a few minutes, that there were a number of different options, but the scaffolding with the bare metal stent addressed some of the limitations with prevention of the acute thrombosis and recoil. And obviously, restenosis remained an Achilles heel of this therapy in the introduction of drug-eluting stents, and its maturation over the past several years, I think, has obviously allowed this to be, really used in a great number of patients, more lesions, et cetera. But as you can see here on the slide, I think even though the goals of therapy are to relieve obstruction and sustain acute gain, which the current generations of drug-eluting stents have done extremely well, we achieve this at a price. And I think you alluded to that. This is adapted from a great review paper that just came out in Circulation. The format of this is if it's a minus, it means it doesn't address it. If it's a plus, it means it does. And you can see that plain old balloon angioplasty, while it did achieve acute gain, really didn't address some longer-term issues. And as we went into a scaffolding with bare metal stents, we improved on some of these limitations. And really, I think right now we're at a time when we're comfortable with the performance of drug-eluting stents, but I think the Achilles heel that we're all concerned about is sort of the long-term consequences of having the risk of a stent thrombosis and, of course, having to take medications that are designed to prevent that. So in this kind of, sort of conceptual and actually practical framework, I think, we need to look at some of the things that PCI really doesn't address and that we really need in the future. So we really have to eliminate or minimize the need for long-term dual antiplatelet therapy. And there's two elements to this. One is that we need to eliminate the occurrence of it itself. Of course, that would address the problem entirely. If we're able to, of course, reduce the risk of it, even though it was present, then we need to reduce the exposure that we need to have with dual antiplatelet therapy. Now, when we first looked at plain old balloon angioplasty and tried to address some of the limitations, I think there were a number of different ways that it could have been achieved. The rigid cage with stents was technically, I think, the most feasible, and the question is, really is this the most optimal way in today's, sort of interventional cardiology world to achieve this, or can we do something better so that achieving, the preventing recoil and restenosis, can we do that without taking away some of the options? So we have examples of full metal jackets where it's not quite clear where the if they needed a bypass. So that's just one of the, potential areas for development. Restoring a healthy vascular sort of function is an area that we haven't spent a lot of time thinking about. But if you go back to the late 1990s and early 2000s, a couple of really interesting clinical trials took patients and divided them in those who had normal vascular responsiveness and those who didn't, and actually followed them and found out that those who did not have a normal response to some of the medications to look at endothelial function actually had more clinical outcomes. So I think there's really some background here for us to think that this isn't an area that we've explored actively, but potentially would be I think an improvement on what we currently have, because we know downstream in patients who have the limus drugs, for example, that endothelial function seems to be abnormal or persistently abnormal. Of course, the last is it would be nice to be able to image through them. We're having rapid evolution of non-invasive coronary imaging with CT, with MR. And in the future, if we could image through these, particularly in the left main, for example, where I think it seems to be an optimal use of non-invasive imaging. So I think we have some areas for improvement on the current, even though, excellent drug-eluting stent therapy. And these are, I've listed what I consider to be the 5 strategies that we have that are in development or are currently in use. So we have the next generation drug-eluting stents. They still use a metallic platform, but they're thinner struts, presumably less harmful to the vessel, lower drug doses, less inflammatory polymers. So we're addressing some of the issues, but not all of the issues. We have bioresorbable polymers on thin strut stents. And if we can, sort of eliminate the inflammatory component of the drug-eluting stent, perhaps that'll be good. This is obviously an area that's under active clinical investigation. We have drug-eluting BMS without polymer, basically spraying on a coat, and in animal models anyway, this seems to work. Drug-eluting balloons are an exciting area of research. I think they may have a role in the periphery. Whether or not they'll ever achieve a dominant role in the coronary is not clear. And of course, we have fully bioresorbable drug-eluting stents.
Bob, this slide should remind our viewers that drug-eluting stents are actually very complicated devices. There are multiple parts to these things, and the biology of the ultimate outcome may be related to any one of those particular pieces. Would you agree with that?
Oh, absolutely. I think, in fact, we'll talk a little bit about that in a minute, and I have a slide that I think sort of looks at the vascular events that occur once we put one of these in, and all the elements that are there. So from a conceptual point of view, in terms of addressing this limitation of the current PCI therapy, I think only bioresorbable stents really offer a solution to all of the issues that we just mentioned. And we'll go over some examples, I think, in a minute of what that are. Now, it shouldn't be surprising that we're talking about bioresorbable materials for use as a coronary scaffold, because, in fact, they're very common in healthcare today. I think many of us would probably say, well, yeah, we have the screws in orthopedic devices, and there's a whole host sutures for our own interventional practices. Many of us who use closure devices are aware there's a bioresorbable closure device. So it's really not a novel idea. What is novel, though, and has been challenging, is the fact that these bioresorbable materials are a little bit more difficult to work with. They resist deformation. Sometimes they have breakpoints that we're not used to seeing with metallic stents. And I think one of the reasons why we went to the metallic stainless steel scaffold is because it was much easier to work with and achieve the early goals that we wanted to. I thought you might be interested in this little plug here for Duke. I came across this in doing some background sort of reading on this, and it's interesting that 1983, as part of really a inventory of innovative devices that were undergoing development here at Duke, with the tech atherectomy catheter, with a perfusion balloon, that a bioresorbable polylactic acid stent actually was undergoing clinical testing, and in 1988, I think we see that a balloon expandable stent was developed here. So we're going back a couple of decades here, and one wonders in the past 2 decades really what's been going on, and I think the answer is, frankly, is that bare metal stents really just hit a home run and did so well with their acute performance, and the fact that there are some technical issues in terms of bioresorbable materials in developing into a stent that I've gone through. So I just list a few things here just as a way of looking at really some of the the background. I think the key was the PLLA refers to the poly-L-lactic acid, and that is really, I think, going to be the backbone for probably the workhorse bioresorbable stent as we go into the future. But a number of laboratories and really enterprises have been involved in the development of this in the animal model. The first clinical application of this actually was in Japan in the late 1990s with the Igaki Tamai stent, which is a fully biodegradable. You can see that on the left-hand portion of this slide. PLLA again, so poly-L-lactic acid, which forms basically a rigid cage allowing the scaffolding. It's interesting, the red arrows there are pointing to the fact that there are metallic markers on the end of this because the polylactic acid stent is completely not visible by standard X-ray. This is also interesting. So they, at the initial and 6-month clinical follow-up, clinically there was good acute performance, very stent-like behavior, very low MACE rate at 30 days. And a 6-month late loss of 0.48 millimeters, which was very comparable, in fact, perhaps even better than bare metal stents available at that time. Now, what slowed down the Igaki Tamai stent was the fact that this stent was both self-expanding, requiring heated contrast up to 70 degrees, as well as some balloon expansion to achieve its final dimension. And I think there was some concern early on that there may have been some long-term sequelae of the heat that was unexpected. So,
yeah, certainly our experience from Rotablator told us that heat is probably a bad thing.
Yes, indeed. Yeah. So I think, though, that this was obviously a very intriguing, sort of study and technology that, again, because of the success of the stainless steel stents, really had just kind of pushed this to the background. There followed shortly thereafter in animal development and then in a series of clinical evaluations, a magnesium alloy stent, which had properties very similar to a bare metal stent and underwent evaluation in the coronary circulation in 63 patients as part of a prospective registry. Unexpectedly, the magnesium bioresorbed at a much faster rate than was anticipated, and in fact, probably a great deal of this was bioresorbed by 6 weeks. As a result of that, TLR rates were 48.4%. And we know that it was the actual early bioresorption of this, because if you look at the stented area, it had reduced substantially and contributed to the late loss and the TLR rates that were there. So some good aspects of this, and the acute performance was good. And I should say in both of these, both with the Igaki Tamai stent and the magnesium stent, that there were no issues with stent thrombosis. So taking away, some of the concern about what would happen acutely.
What's the physiology here? Is this similar to what we see with balloon angioplasty in terms of recoil as the restenotic process in the with this particular stent, the magnesium alloy stent?
Yes.
Okay, so it's a recoil phenomenon, basically the lack of scaffolding. Okay.
Yeah, absolutely. So you're reading my mind here. I think that this was a time when this, technology took a pause, but I think there were two important points that I think that the industry took away with this, and one is that there really was proof of concept that we could take a bioresorbable material, introduce it into a coronary artery, just as we would a bare metal or drug-eluting stent, and achieve acute outcomes that were very comparable. Of course, with the Igaki Tamai stent, there were some issues about the delivery system itself, but the proof of concept was there. I think actually the experience with the magnesium alloy stent in some ways may have been more instructive for this technology, because it really made us understand that there is a time frame during which perhaps optimal sort of scaffolding of the platform needs to occur, and it is longer than probably 6 weeks. We'll talk in a minute about some of the rationale why it might be 3 months. And neither one of these were obviously drug-eluting stents at this point in time. So with our understanding of the benefit of drugs to inhibit neointimal formation, I think we achieved a better understanding of where to go with this. So you were asking me earlier about some of the stents are really very complicated devices, and we can see why they may need to be complicated devices when we look at the vascular responses here. This is a cartoon which really we break this down into several points. So if we look at the boxes here with the colors, we see platelet deposition, thrombosis, leukocytes, smooth vessel cell proliferation and migration, all of which are initiated by what the vessel believes is an injury. And in some ways we all learned in medical school as a healing response. And we can see that some of these occur over different periods of time. Now that's all on the sort of cellular basis, but we also recognize from the result with the magnesium stent that vessel recoil as well as negative remodeling occur in the first 3 months, and it's very important that the stent scaffold actually provide a way of treating this particular response. So we can see here that if we were going to design a bioresorbable stent, really there are 3 phases. In this cartoon, it's listed as revascularization, and really that just means that we've achieved lumen, gain, and we've maintained it. We know that showing here with the everolimus solution that it's important to inhibit the neointimal formation. And then, of course, in restoration, we're going from that scaffold period to the time when we're allowing the vessel wall to undergo its normal vascular responses. So a very complex process, and I think we need very complex answers. So one of the questions that comes up is, well, bare metal stents, the stainless steel and now the cobalt chromium or the platinum, have done a great job. Don't you really need something that's strong enough to maintain this scaffolding so that we don't have the vessel collapse and we don't have this negative remodeling that occurs? And shown here on the top are just some examples of currently available metallic stents. So, and these are the radial strength that's achieved by them. And you can see on the far left the Absorb, which is a polylactic acid, completely bioresorbable stent, has radial strength, which is very comparable to that of the cobalt chromium Science V stent. So I think this doesn't tell us, what is the absolute optimum radial strength that we need, but we recognize that the Science V with, its clinical trials has shown us, very good, I think, efficacy. So we can just, extrapolate. I think that this ought to be sufficient. There's some interesting data going back into the plain old balloon angioplasty era. This is from actually Soroy's lab, who looked at serial angiograms 1, 2, 3, and 4 months after an angioplasty, and found that actually the restenotic process really peaked at 90 days, and from 90 days to 120 days really didn't see further advances, suggesting that whatever the proliferative process was, the negative recoil was probably completely had worked its way through its cycle at 90 days. So we could probably use that with the data from the magnesium stent experience with this data, and that's really, I think, the target that we're going to have. So we alluded to the fact earlier about what might be an ideal stent going forward in the future, and it would be something that would really restore vascular, I think, health. This is some data that indicates, in fact, that this may be the case. These are from the Absorb trial, and this is looking at endothelium-dependent function with the acetylcholine infusion. Of course, normal endothelium responds with a vasodilatory effect, and atherosclerotic or diseased with a vasoconstrictor effect. And we can see here that both in the proximal and distal segment of the vessels treated with a bioresorbable stent, that we have normal vascular responsiveness. In fact, even in the treated segment, there appears to be. So this is not just, I think, a theoretical, sort of ideal goal. I think we can now show that with the bioresorbable stent, we see this. In fact, some of the data which I haven't shown with the magnesium stent alloy also did some of the similar testing and were able to demonstrate this. So the linkage to whether or not this is going to reduce chances of heart attack or an acute ischemic syndrome, I think remain to be determined. But certainly there's some intriguing, I think, information that suggests that's where we're going to go. In kind of an interesting serendipity, a bare metal, a bioabsorbable stent was deployed next to a cipher stent in a patient, not at a target lesion though, and Dr. Chevalier showed this at PCR, and we can see here with a fast CT image that the cipher stent completely blocks the ability to see inside the vessel, and all you see with the bioresorbable stents are actually the markers on both ends of this. So just as an example of the potential as we go forward with this kind of technology. So there currently are 5 programs in development. We'll just talk briefly about some of these. And we talked about the Igaki Tamai and the magnesium alloy. We have 3 others, the Absorb or BVS, polylactic acid, tyrosine polycarbonate, and novel salicylate. We'll just talk quickly about some of these technologies. Really, I think the point that I wanted to show here was that the absorption products for all of these stents really are all biologically normal materials, and it's important to understand that the resorption process occurs within the walls of the vessel in a fashion that is very akin to the normal physiology of the coronary circulation, and that concerns about sort of embolization and breaking off really have not been observed. So,
and in terms of the actual resorption, these are biologically inert ultimately what they end.
And most of them are CO2 and water, and magnesium, of course, is a naturally occurring alloy as well. And the other point I want to show on this slide is the fact that most of them now in their latest iteration have achieved a bioresorption time that exceeds probably 6 months, and in fact the scaffolding, so the durational radial support recognizes that the 3-month time frame is really, and this is going to be, I think, as we go forward with all of these.
Is strut thickness at all an issue with these particular devices?
Well, they're not the new generation thin cobalt chromium stents. That's certainly true. So if you look at these, almost all of them are about at the same strut thickness of the original cipher and taxa stents.
I see.
And so about 150 microns. And currently, for example, the Science V platform is 81 microns. So there's going to be some obviously opportunities to thin these out. But I think that the currently the ability to achieve the acute gain in the scaffolding requires the thicker struts. So this is the tyrosine polycarbonate stent. A couple of novel features here. This ultimately undergoes degradation through the Krebs cycle as well. It has basically a slip and lock design. You can see probably more clearly on the bottom left there, so that there really isn't much deformation of the struts themselves. It incorporates an iodine molecule, so it's the only one of the bioresorbables besides the metallic magnesium stent which actually can be seen under X-ray, which is an advantage. This was tested in a small number of patients in the Resort trial with very high TLR rates, and obviously, like the sort of infancy of drug-eluting stents, not every stent is going to be a home run out of the gate, and I think there's some development needed there. The salicylate adipic acid polymer stent shown here is novel in the sense that the salicylate itself is, of course, anti-inflammatory, and I think it was hoped that besides acting as a backbone with enough radial strength to achieve, a stent-like result, that it would essentially sort of passivate the vessel. Unfortunately, in its current iteration, even with sirolimus, there was excessive hyperplasia, and I think again, this is currently in animal models. So the last of these, I just want to spend a little bit more time talking about because we have a fair amount more data, and I think just giving us some great insights into what we can achieve with this and where we need to go is so this is a polylactic acid based platform. There are really two components to this. There is a crystalline poly-L-lactic acid, which gives it its strength, and then there's a poly-DL lactic acid coating, which is an amorphous array, which undergoes faster, bioresorption, and is where the drug elution comes from. So this is a cartoon which I think helps us understand, what I consider to be some of the key responses of this. So we're going to talk just real quickly about three trials here. The Spirit First Science V, which is, of course, the drug-eluting stent comparator here, and not that these were all in a randomized trial together, but serves to give us an understanding what we should achieve with a new generation drug-eluting stent of a late loss of 0.10 millimeters, most of which is due to neo-animal hyperplasia. That is the standard now, I think, with DES, and really is what we've come to achieve. In the Absorb biovascular scaffold 1.0, the initial version of this, what was observed was great acute performance. There was only one non-ST myocardial infarction in the first 2 years, and no stent thromboses. So really, very small numbers, of course, in 30 patients, but
encouraging.
Very encouraging. And what we saw from, and these patients underwent extensive evaluation with angiography, intravascular ultrasound, OCT, palpography, CT scanning, to really give us a much better understanding of what's going on at the vascular level. And we saw a late loss of 0.44. Now, this is a drug-eluting bioabsorbable stent, so a little disappointing that we had this, but I think what was recognized is that a great deal of this actually was from probably inadequate scaffolding at the 3-month time period, and very little neo-animal hyperplasia, as we can see there. In fact, less than was observed with the Science V stent. So this was revised. There was additional stent coverage provided, and at 6 months we can see here that the absorbed cohort B, as many of you are aware of, with the BVS 1.1, actually was able to achieve a late loss of 0.199 millimeter, putting it in the, I think, really in the category of a very effective drug-eluting stent. So very, very encouraging and exciting results. Some of the things, I think OCT is emerging as a very interesting way to look at the coronary vasculature, and we're learning things that we're not quite sure what to do with them, but I think this is a perfect technology to help us understand what's going on with bioresorbables. And we can see on the upper panel here what looks like little box cards as they've been come to known at the time of placement, shown at 6 months, and then at 2 years. In this particular example, complete resorption in this frame, and what appears to be almost a normal coronary artery. Shown down on the bottom, and the reason I show this is at 6 months we can see that there is a thin layer of endothelium over all of the struts, suggesting and confirmed both by animal studies and OCT that there is almost 99% strut coverage, which obviously is what we would expect as an ideal healing mechanism. Now, to determine that coverage, in fact, is healthy endothelium remains to be determined, but I think the vasomotor responsiveness that we saw earlier suggests that, in fact, that will be the case. So let's just move forward a little bit to what's actually out there right now. We have two stents, bioresorbables, that can be available in clinical use in Europe. So the Agaki Tamai stent received CE mark approval in November of 2007 for peripheral interventions, and the Absorb or BVS bioresorbable polylactic acid stent received CE mark approval this past January. Now, it is available for coronary interventions. I think what we will expect to see is over the course of the next year and a half or so, refinements in this technology as we get the 2-year results from the Absorb B cohort, and clearly I think everybody wants to make sure that we do this right. So future challenges of bioresorbables, I think the first is to convince the interventional community that this is a viable technology, and I think the foundation has been laid, and I think with definitive clinical trials demonstrating non-inferiority to the current next generation of drug-eluting stents, we'll have the knowledge base and the information that physicians need to be armed with. The 3 trials right now, the Absorbed Extend is ongoing as sort of an outgrowth of the cohort A and B, so that's available and expected to enroll over 1,000 patients. Approximately 250 were enrolled as of this July 1st. 2 randomized clinical trials, one outside of the United States. Absorb 2 is going to be interesting because it's going to be using vasomotor function as its primary endpoint. Again, trying to, I think, cement this element of aspect of this, which differs from our current technology. And the Absorb 3 will be a 2,000 patient randomized clinical trial in the United States, designed to determine the clinical efficacy. Many people ask, is this going to be a workhorse stent? Is this just going to be a niche stent? And I think obviously we're going to have to determine that. The ability to pull a catheter off of the shelf just like we currently do and have the same expectations of deliverability and efficacy remain to be determined, but certainly encouraging. We need to determine the long-term benefits of vascular healing, as we've discussed here on a couple points, and I think this is, again, intriguing. And the last and always sobering is the fact that in today's healthcare economic climate, that cost effectiveness is going to have to be demonstrated because the technology required for this, the production, is really a little bit different than it has been in the past, and certainly there are going to be some questions asked about that. So as my summary of this, a very exciting new technology, I think, for us. It's not available on the shelf yet, but the proof of concept has been demonstrated, and I think that we can expect to see a lot more data. Its role in everyday practice, I think, is going to be determined by the efficacy studies as well as the ability to really get to the places that we currently do. But I'm encouraged because multiple devices are really under development, and I think when we see that, we know that people think that this is a very viable technology. So
this is terrific, Bob. I mean, this is a real glimpse into the future, and I think very exciting times. How long, if I were to ask you to speculate, do you think it's going to be before we start seeing these in clinical practice in the U.S.? Are we talking about a decade? Are we talking about 5 years?
Great question. We need somebody from the FDA to answer this question. But
yeah, I imagine that there are some regulatory hurdles here, aren't there? Because this is somewhat of a breakthrough technology. So ultimately, it comes down to, obviously, everyone's interested in the efficacy, but it seems to me the promise of this is really on the safety side. And now we're dealing with stent thrombosis rates that are so low. It may be challenging, to try and show convincing safety, in sort of a 2,000 patient trial. So I think you're right. I think that may be a challenge.
Well, I think, to look at the timeline, I think many of us expect that the randomized clinical trial will begin in the United States in 2012. Mm-hmm. It's going to be a 5-year study, and obviously late stent thrombosis as a clinical endpoint really doesn't emerge until the second year of follow-up, because that's when we're really looking at the late issues. So I think we're looking at a minimum of 5 years. I think that the time period between 5 and 10 years from now is certainly not unreasonable. But I think during that time period, though, that the thought processes of the clinicians is something that's going to undergo somewhat of a change. And I think just besides the simple I see it, I treat it, and I move on is part of the process that we'll go through, challenging ourselves to understand if in fact this new paradigm is where we should be.
Well, can you tell us about sort of the technical aspects of how to put these in? I mean, have any of these studies looked at direct stenting? How much can you post-dilate these things without cracking the polymer? Do we know anything about that so far?
Well, I think obviously these are great questions, and this aspect of the technology is what's going to determine whether or not this is going to be a niche product or whether or not this is going to be a workhorse everyday stent. Now, currently, we talked about the strut thickness, so I mean that's clearly one limitation at this point in time, and we know one of the reasons that we've had such a proliferation and success is the downsizing of strut thickness, number one. I can tell you this though, in the wet models that I've personally been able to use, these stents are deliverable, so I don't think that's an issue. The ability to post-dilate these stents, I think, is an issue that needs to be addressed, and certainly there is a break point of these stents. So putting in a small stent and saying, oh, I think I need a bigger stent, and then post-dilating it is something that you won't be able to do with this. So, and obviously we're all using very small guide catheters these days. So I think it's something that's we need to develop.
Yeah, I mean, it's interesting as we start thinking about the development of bioresorbable platforms. There's this whole sort of drug-eluting balloon that's in the background that's you said has some pretty decent data in the periphery. It would be interesting to think about a BBS on a drug-eluting balloon, although I suspect no one's actually done that yet. Or am I wrong? Have people thought about that you know of?
I'm not aware that they've put those two particular technologies together. One of the concerns about that is the sort of the ability to deliver the balloon. What order do you do this? Do you do the drug-eluting balloon first and then followed by the stent? Do you put the stent in? And I think there's probably some novel sort of strategies that could be developed. I think there's so much involved in the technology to achieve a bioresorbable drug-eluting stent right now that most of the effort is really going to be headed in that direction.
I agree. Now, you mentioned at the end there cost-effectiveness, and I think that's an incredibly important issue. You recently had a very nice publication looking at cost-effectiveness of drug-eluting stents. It's going to be a little bit of a tangent, but I think it's relevant to the overall stent issue. Tell us a little bit about your study and what you found when you examined that.
So we have had a stent registry at Wake Forest for probably going on 5 years now. And so we've been able to really look at events in patients who had bare metal stents and drug-eluting stents. And we had a cohort of patients that represented the last year of bare metal stents and then the first year of drug-eluting stent when their use was approximately 90% in our institution. So we had two pretty pure groups of patients matched in all respects about why they had it done and the lesions and everything else. And so we followed their clinical outcomes and in a series of publications have shown that, on almost all fronts, the drug-eluting stents had lower event rates. So when we looked at the cost effectiveness of the drug-eluting stent versus the bare metal stent, we saw that during the pure cost analysis of events and the device itself, that the cost of the device was completely offset by the cost of reducing later events. What we didn't expect, and I think it was probably a novel finding, is that the use of dual antiplatelet therapy really affected the cost effectiveness analysis. And so that over the course of the study, which was out to 3 years, it was approximately $4,500, I think, per TLR avoided with the use of drug-eluting stents. Most of that driven by the fact that so many patients had to take dual antiplatelet therapy.
I see.
In the context of a number, I think $4,500 is certainly going to be debated whether or not you're the patient, whether or not you're the hospital, or whether or not you're the payer, but certainly well within what other published findings have been with the Cypher stent, for example, in the randomized clinical trials in Texas. So,
yeah, the thing I really like about that study is the fact that you accounted for the dual antiplatelet therapy. I think in previous sort of older cost-effectiveness models, they sort of haven't taken into account the overall healthcare delivery picture, which, like you said, involves not just the device, not just the TLR, but the fact that the patient has to take additional therapy as a consequence of getting this device. And it'll be interesting to see, I think, with the BVS, how the dual antiplatelet therapy practice patterns are going to change and how that's going to impact the cost-effectiveness of the device. So I think we've got a lot of exciting things to look forward to, a lot of things to debate, I think, in the future.
Absolutely. That's what keeps us in a job.
That's right. Well, this has been a terrific program. My guest faculty today has been Bob Applegate. Bob, thanks again for joining us.
My pleasure.
And for a terrific talk. Until next time, then, from all of us here at Duke, this is Sunil Rao saying thanks for joining us and take care.